Hello everyone. Today we are going to talk about the management of the postpartum hemorrhage. So let's go with the topic. So for the postpartum hemorrhage, like the definition which is given by the WHO is that the amount of blood loss in excess of 500 milliliter following the birth of the baby. So this is given by the WHO, and for the clinical definition, any amount of bleeding from or into the genital tract following birth of the baby up to the end of the puerperium, which adversely affect the general condition of the patient, evidenced by the rise in pulse rate and falling of the blood pressure. So uh, any blood loss that make the woman symptomatic, then we have to regard it as postpartum hemorrhage. So the average blood loss in the single on vaginal delivery is 500 milliliter, and for the cesarean delivery or the twin vaginal delivery, there will be average blood loss is 5,000 milliliter, and the cesarean hysterectomy there will be the blood loss of 1,500 milliliter. So there are two types of the postpartum hemorrhage: primary and the secondary. Like primary is that the hemorrhage occur within the 24-hour following the birth of the baby, and the secondary is that the hemorrhage occurs beyond 24 hours and within the puerperium. It is also called as delayed or late puerperal hemorrhage. And the type of the primary hemorrhage is like third stage hemorrhage, which occurring like bleeding occurs before expulsion of placenta, and the true postpartum hemorrhage, bleeding occurs subsequent to the expulsion of the placenta. So it is termed as true postpartum hemorrhage. So we have to, let's talk about the primary postpartum hemorrhage. The causes of the primary postpartum hemorrhage is like we have to remember 40, like tone, trauma, tissue, and the thrombosis. For the tone, atonic uterus is the one of the most common cause of the primary postpartum hemorrhage. So 80% it takes like 80% most common, and the genital tract trauma second most common, and retained tissue, blood coagulation disorder, and drug like trauma, tissue, and the thrombosis like blood coagulation disorder and drugs. So the talking about the atonic uterus, most common cause of postpartum hemorrhage is atonic uterus in the primary hemorrhage. After the separation of the placenta, uterine sinuses which are torn cannot be compressed effectively due to imperfect contraction and retraction of the uterine musculature, and bleeding continues. And the condition favoring the atonic uterus is that grand multiparity. It is like the parity of equal or greater than 5, and over distension of the uterus. It is mainly in the big baby, twins delivery, polyhydramnios. So in malnutrition and anemia, antepartum hemorrhage, prolonged labor, anesthesia, uterine fibroid, mismanaged third stage of labor, and the placenta like accreta and the porcreta placenta can also contribute or favor the atonic uterus. So in the traumatic, like trauma in usually involves the cervix, vagina, perineum, periurethral region, and rarely rupture the uterus occur, and the retained tissue. The other causes like retained tissue, there is the beads of the placenta, blood clots, which can cause postpartum hemorrhage due to the uterine retraction. And the drugs like tocolytic drugs like rituximab, magnesium sulfate, nifedipine, this can also be contribute to the postpartum hemorrhage. And the blood coagulation disorder or acquired or congenital can also be contribute to the postpartum hemorrhage. So for the diagnosis and the clinical effect, like in the majority, vaginal bleeding is visible outside, and the effect of blood loss depend on like the hemoglobin level before the delivery, and the degree of pregnancy induced hypervolemia, and the speed at which the blood loss occur. So it is mainly effect of blood loss depends on these factor. And the alternation of the pulse pressure appears only after the class 2 hemorrhage, like 20 class 2 hemorrhage means 20 to 25% of the blood loss. So status of abdomen in traumatic uterus in well contracted, and in atonic hemorrhage uterus is become flabby and becomes hard and massaging. So both atonic and traumatic hemorrhage may coexist in these many cases. So the prognosis of the postpartum hemorrhage is that it is one of the life-threatening emergencies, and the morbidities like shock, transfusion reaction, puerperial sepsis, failing lactation, pulmonary embolism, thrombosis, and the thrombophlebitis. And the late sequel includes Sheehan syndrome, like there will be there will be less blood supply to the pituitary, so pituitary hormones will be less synthesized, and the diabetes insipidus. This can also be seen the prognosis of the postpartum hemorrhage. So for the prevention, like in the antenatal improvement of the health status, high risk patient, we have to take care of high risk patients, blood grouping, placental localization, women with morbid adherent placenta. So we have to take care uh, for these patients. And in the internatal, like active management of the third stage cases with induced labor by oxytocin, women delivered by cesarean section, oxytocin 5 international unit, slow IV is to be given to prevent blood loss, and the exploration of the uterovaginal canal, observation for about 2 hours, and examination of placenta to detect the missing part, so that the placental bits do not remain there and causes postpartum hemorrhage. So for the management of the third stage of the bleeding, as we have already talked about, the third stage of the bleeding is that the before the removal of the placenta. So we have to control the fundus and massage and make it hard, and inject methergine 0.2 mg intravenous, and to start the normal saline drip with oxytocin, and arrange for blood transfusion and catheterize the bladder to measure the output. So if after giving this therapy, then placenta is separated, then the express the placenta out and by control cord traction. But if it is not separated, then we have to do the manual removal under general anesthesia. If there is traumatic hemorrhage, then we should tackle by the suture. So how can we do the manual removal of the placenta under general anesthesia? Let's see about that. So for the step of the manual removal of the placenta, the step one is like operation is done under the general anesthesia, and patient is kept in the lithotomy position, and the bladder is catheterized with all aseptic measures. Then one hand is introduced into the uterus after smearing with antiseptic one hand should be introduced into the uterus after smearing with antiseptic solution in cone-shaped manner, following cord, which is made taut by the another hand. While introducing the hand of the labia is separated, hand should locate the margin of the placenta. The counter pressure on the uterine fundus is applied by the another hand placed over the abdomen. So another hand placed over the abdomen, and the abdominal hand should steady the fundus and guide the movement of the finger inside the uterine cavity till the placenta is completely separated. So as soon as the placental margin is reached, the finger are inserted between the placenta and uterine wall, with the back of the hand is in contact with the uterine wall, and the placenta is gradually separated with the side with slicing movement of the finger uh, until whole of the placenta is separated, like slicing movement of the finger, so that until the whole of the placenta is separated. And when placenta is completely separated, it is extracted by the traction by the cord by another hand, which is kept at the abdomen at first. The uterine hand is still inside the uterus for exploration of the cavity to make sure that nothing is left, like placental beads or blood clots, nothing is left, so that it can contribute to the postpartum hemorrhage later. So we have to ensure that. And intravenous methergine 0.2 mg is given, and the uterine hand is gradually removed while massaging the uterus by the external hand to make it hard. So after completion of the manual removal, inspection of the cervicovaginal canal to made to exclude any injury which is causing while the manual removal of the placenta. So the second common cause of the postpartum hemorrhage is trauma. So we have to inspect the cervicovaginal canal to exclude injury. At step 7, the placenta and the membrane are inspected for completeness and to be sure that uterus become hard and contracted. And the difficulty, like our glass contraction, like this type of glass, like if there is in the hollow organ, like uterus, stomach, if there is like in the middle portion, if it is contracted, then there will be our glass contraction, leading to difficulty in introducing the hand. Morbid adherent placenta, which may cause difficulty in getting in the plane of cleavage of placental separation. In this case, the placenta is removed gently in fragment using the ovum forceps. So the complications are like hemorrhage due to incomplete removal, shock due to the uterus infection, inversion, subinvolution, thrombophlebitis, and the embolism. So for the management of the true postpartum hemorrhage is the blood loss subsequent after the removal of the placenta. So it is very important. So let's talk about this. For the management of the true postpartum hemorrhage, first you have to call for help. First thing you have to do is call for help, and then you have to do is a quick vital assessment. You have to do the quick vital assessment. Then you have to open the two vein, two cannula is opened, and then one cannula is used for the investigation to send the blood for the investigation, like cross match, coagulation screening, including fibrinogen and other. And other is used for infusion of the rapid infusion of the 1500 milliliter of the crystalline RL Ringer's lactate solution. So it is rapidly infused. And third thing, like you have to count the finger at the first thing, call for help, then do the quick assessment of the vitals, then open the two cannula, for one for the cross matching, sending cross matching, and the next for the 1500 ml crystalline RL solution. And this finger denotes that you have to catheterize the bladder, and this finger is to tell somebody to monitor the BP, pulse, like vitals, SpO2 50 in every 15 to 30 minutes. So for the remembering, you have to take the 5 finger and 5 steps of the immediate measures you have to do to manage the true postpartum hemorrhage. Then you have to do the abdominal palpation to feel the uterus. If the there can be uterus atonic, or the uterus can be hard and contracted. So if the uterus is hard and contracted, then there is no atonic uterus. So the next common cause is like traumatic condition. So we have to do the exploration if there is any trauma in the cervicovaginal canal or on anything. And if we found that, then we have to do the hemostatic suture at the tear site. And for the if the uterus is atonic at the abdominal palpation, then you have to massage the uterus to make hard, and to add oxytocin 20 units in 500 milliliter of the saline, or in Pattern hospital it is in the RL solution, mainly given in the RL solution. And after the delivery, every mother is giving we have to give every mother like 10 units of the intramuscular oxytocin. But if we that uterus is atonic and there is a postpartum hemorrhage, then we have to give the 20 unit of the oxytocin. But in this time we have to give the IV and infusion, like in the 500 milliliter of the normal saline or RL solution. So if this do not work, or the effect is not seen rapidly, then we have to inject the methargine, which is we have to give 0.2 mg intravenous. We can also give intramuscular in this case. And the injection of the methotrexate is contraindicated in the eclampsia, preeclampsia, and heart patient and the perivascular or like peripheral vascular diseases condition. So we have to we do not have to give the methotrexate injection for these patient. So we have to take the history of the patient carefully before the delivery, so that we can exclude this. And why these patients are not giving methotrexate is that like it is methotrexate contact the uterus very much, so that the large amount of blood will be goes to the heart at the same time. So then many complication can occur to the patient. So we have to we have to contraindicate this drug. So then we have to examine the placenta, like if there is any missing part in the expelled placenta, so we have to examine it as also. Then again that the uterus is remain atopic, then the exploration of uterus is done, and the blood transfusion is given, and to continue the oxytocin drip. And then if the uterus is atonic, then we can give like 15 methyl prostaglandin F2 alpha 250 microgram intramuscular or intramyometrial, or misoprostol 1000 microgram per rectum, or carbitocin 100 microgram intramuscular or intravenous. Mainly like misoprostol 1000 microgram or 800 microgram is generally given, but you have to give the per rectally. Then again the uterus is atonic, then we have to do the uterine tamponade. There are balloon tamponade. If the balloon tamponade is not available, we can also use the Foley catheter, but we have to use the condom, so that and then the saline is infused to that, and then it will be swollen, and then works as a balloon tamponade. And bimanual compression can also be done, like if this is uterus, then the fist of the hand is one hand is placed inside the uterus and from the abdomen, then another hand like bimanual compression can be done, or tight intrauterine packing under the anesthesia can be done. And again the uterus is atonic, then we have to go to the surgical method. For the surgical method, so stepwise uterine devascularization procedure. First, like B-link compression and multiple square suture can be given to the uterus, and this type of suture, if this is the uterus, then this type of suture like B-link suture, and then the ligation of the uterine artery and utero-ovarian anastomosis vessels, unilateral or bilateral, can be done, and the ligation of the anterior division of the internal iliac artery should be done. We should not have to ligate the common iliac artery, because it supplies the other part also. So only the internal iliac artery, and specifically anterior division of the internal iliac artery, is ligated. And the angiographic arterial embolization with gelatin sponge, it is mainly done in the uterine artery. So again, if the uterus is like postpartum hemorrhage is not stopped, then we have to do the hysterectomy, but rarely these above methods works. And then we have to, if like bleeding control, then the continuous observation in high HDU unit and ICU, and documentation of the procedure adopted in respect to time. So it is the guideline of ARCOG, FIGO, and ACOG. So for the secondary postpartum hemorrhage, the main causes is retained placental beads and infection, endometritis and subinvolution of the placental site, and secondary hemorrhages from cesarean section wound usually occur between 10 to 14 days. Withdrawal bleeding following estrogen therapy for suppression of lactation. Rare causes like chorion epithelioma, carcinoma of the cervix, placental polyp, infected fibroid, and puerperal inversion of the uterus. So for the diagnosis, bleeding is bright red and of varying amount, and the varying degree of anemia and evidence of sepsis are present. And in USC, useful in detecting like any bits of placenta is remaining in the uterine cavity, so USC is useful for the management to assess the amount of blood loss and the turn and to replace it, and to find out the cause and to take appropriate step to rectify it. For this three therapy like supportive therapy, blood transfusion, administration of methadone 0.2 mg intramuscular if the bleeding is uterine origin, and to administer antibiotic as routine. For the conservative therapy, if the bleeding is slight and no apparent cause is detected, a careful watch for period of 24 hours must be done. And for the active treatment, exploration of the uterus under general anesthesia, should not ignore the small amount of bleeding. And the products are removed by the ovum forceps, and the gentle curettage is done by using flossing curettage, and methotrexate 0.2 mg given intramuscular, and the material removed is sent for histological examination. And like presence of bleeding from the sloughing wound should be controlled by the hematostatic suture, and the secondary hemorrhage following cesarean section may at time of require laparotomy. So the reference TC Dutta, and thank you.